Awesome. So I'm Dr. Harita Raja. I am a women's psychiatrist in the DMV area. And I'm really excited to be here. So thank you all for being here with us today.
And hi, everyone. I'm Dr. Heather Quaile. I'm a women's health nurse practitioner, and I am in the Georgia area. My background is midlife and women's care, and I'm really excited to be here with you all as well.
So I am going to go ahead and talk about trauma a little bit. So many women experience trauma. There are studies that show as many as 90% of women will experience trauma at least once in their life. But women seem to get confused between, what they can call trauma or not. So maybe we can talk a little bit about big T trauma versus little t trauma.
Absolutely. So I kind of want to start a little bit with just this generalized definition. So for our listeners, trauma is really kind of this psychological, emotional, or this physical response either to like an event or a series of events. And what it does is it actually really overwhelms that person's ability maybe to cope, or feelings of feeling unsafe or powerless or profoundly kind of affected by this. It affects themselves. It affects the world they're in. And honestly, everybody comes from a place of trauma. And I think that's where it's really important to kind of get into this idea of like what we just said, like this big T trauma and little t trauma. Because I think sometimes when we think about trauma, we think about it as this huge catastrophic event with PTSD and all these other things. But really what's going on is this big T trauma refers to like what we think about, these major catastrophic events that pose like this life-threatening thing to the person, where their safety or their bodily integrity has been diminished. They're often sudden, they're very intense, and that's kind of that universal word that we really, really recognize. So think of like natural disasters, war, physical, sexual assault, like accidents, like life-threatening medical conditions. But I think some of the things we don't talk about also is that there can exist this thing called little t trauma. And that's kind of going to be like this more less obvious, maybe like not as big of a cumulative effect, or maybe it's more like chronic stressors. They're not really going to kind of be this life-threatening thing, but really what they do is they kind of impact someone's emotional or their physical well-being. So when we think about it, it's maybe kind of an accumulation of multiple small events. So maybe there's been some neglect, or maybe there's been a bullying or emotional abuse, even like financial stress or workplace stress, or like repeated dismissals and gaslighting. And so I think it's just really helpful to think about like big T trauma is this big hurricane, sudden, destructive, and visible, and little t is more like this ongoing water damage, if you will, like often hidden, and just kind of this, it weakens that foundation.
That's so helpful.
Yeah. So when we kind of dive into just all these different parts and pieces with trauma, can you kind of, Dr. Raja, help us a little bit understand like when this trauma happens, what kind of is going on in midlife, and how does it get reactivated during this time frame?
It's a great question. And, we're going to talk about hormones in perimenopause, and we'll talk about the neuroscience of trauma. But I think we need to talk about some other things that happen during this time that really can reactivate the trauma. So one of the things that we know is that during this time that we see an increase in mood symptoms and anxiety symptoms. So women may feel like they're having more panic attacks in perimenopause. They also may have more irritability. And this can really remind them of the experiences they had with trauma and their response to trauma. So just the re-experiencing of those symptoms can really trigger the trauma to come back in perimenopause and the response to that trauma. We also know that we get a lot of physical symptoms in perimenopause, like hot flashes and night sweats. There can be vaginal dryness or vaginal pain with sex. So those symptoms actually can also be triggering. And so, we really have to look at the somatic sensations that women feel, as well as their emotional health, and how those symptoms can reactivate this feeling of trauma. I'm going to shift focus for a moment, which, one of the things that I think a lot of women can resonate with, there are a lot of life stressors during perimenopause. Some women are caring for their elderly parents. Other women are experiencing a change at work, or maybe a change to their relationship. Maybe their children are leaving the house. They have an empty nest. all of these life stressors can impact us. What we forget sometimes are how those stressors can impact the dynamics between us and a woman and someone else, and how that can reactivate trauma. So let me give you an example. A woman is taking care of her elderly mother because she's an only child, and mom is really sick and she's taking care of her, and there's really no other option. And again, that the dynamic between her and her mother may really reignite some of the trauma response. And then I can't, of course, end this without talking about sleep because sleep is so important. And yet in perimenopause, we know a lot of sleep dysregulation occurs. And when we have sleep dysregulation, it affects memory consolidation, which means basically how your memories are being processed and in your body, and also how you're going to regulate your own emotions. So that emotional fluctuations and unpredictability can happen when we don't have great sleep. And so for all these reasons, we see that trauma can really rear its ugly head again during perimenopause. Yeah, and I think as we talk about this, let's get into the nitty gritty of hormones a little bit. I know that's like the buzzword, but I think women really, as they are educated about hormones and understand what these hormones are doing in their bodies, it can be really helpful for them to be more aware of, how their symptoms are presenting because of that. So be helpful.
Yeah. So kind of what's going on, and a lot of our listeners here probably kind of understand because you're here and that you're maybe in the throes of perimenopause or maybe in full-blown menopause, but kind of like I like to kind of categorize things as maybe like early, mid, and late perimenopause. So kind of in this early perimenopause timeframe. And that's usually, like I say, menopause by definition is right around 51.5 to 52. The symptoms can start several years prior, often around that 5 to 7 years prior. But for some, it can go on 10, 14 years. And of course, when we look at social determinants of health, certain women, in particular, Black women, will actually have worsening symptoms. So all these kind of things to think about. But when I think about it, let's just hone in on what we're here today for is really in this peri time. Early perimenopause, you're really going to start seeing that the progesterone is that first to decline. Maybe like just fewer ovulations that are happening. Estrogen really starts to fluctuate during this time. Estrogen kind of acts as an anti-inflammatory hormone in a lot of ways. So you start to see some maybe insulin resistance, some metabolic syndrome, like they have these weight issues that they don't know what's going on. And then we kind of hit that mid-perimenopause where cycles are definitely becoming maybe a little bit more irregular. These estrogen spikes that we call these loop events where you may ovulate twice in a month, or there's maybe more drops and you're more symptomatic. And then we have this rising of our FSH because that's a hormone that's signaling from our brain, from our pituitary gland down to our ovaries and saying, hey, I need more estrogen. I need more estrogen. And it keeps kind of just spiking it because the estrogen's just not responding like it used to. And then in this late perimenopause, I usually say that's that time where maybe cycles are 60 days or greater apart. And that estrogen and progesterone are really consistently low. That FSH is still raising up higher and higher, leading to that menopause. So when we think about it from like a hormonal perspective, we have this estrogen, and I like to think about it as estradiol, what we naturally make in our ovaries. With all these fluctuations, that really starts to rise, and women may start to see these really high spikes. You heard me say these loop events that happen, where we just have this ridiculous amount of estrogen that gets produced, or ovulations all over the map, and you may see a lot of just breast tenderness and bleeding and migraines. And then with the sharp drop that sometimes happens often in that luteal phase, that back half of your cycle, you're seeing like the hot flashes and the night sweats and the mood swings. And over time, these decline happens with that decreased ovarian function. When we look at progesterone, I've kind of said in peri, that's that first hormone to decline. So again, these more anovulatory cycles that start happening become really common. And that leads to kind of these shorter, irregular, wonkier cycles, lots of heavier bleeding that happens. And then we also see that Dr. Raja had talked about like these sleep disturbances that are happening. A lot of times also kind of in that back end luteal phase of the cycle. And that causes a lot when you're not sleeping well, that leads to kind of the anxiety and the PMS symptoms, and even that middle abdominal belly adiposity and that weight gain. And then that last piece that I can't not talk about being a sexual medicine provider is just that testosterone. Testosterone, I feel like, doesn't get enough homage for females. We often think of these hormones as male-female hormones, and I hate to genderize hormones because we make testosterone as females, and we actually have more testosterone in our body in menopause than we actually do our estrogen. But what we find with testosterone is actually that slowly starts to decline over our lifetime, usually in those late 20s, 30s into 40s, and not just perimenopause. It doesn't just decline, it's been declining all along. And so with that lower testosterone, we see libido changes and the fatigue and the muscle mass. And some women really, really notice this difference with that drop in these different hormones with it as well.
It's not surprising with all these changes that we're going to see an increase in anxiety and mood changes. I mean, clearly women struggle during this time for a reason, and these hormonal changes have a huge impact.
Absolutely. Absolutely. So I think it's really important, kind of as we navigate like what's going on with their hormones. I think we need to spend some time like what's going on in the brain, like what's kind of the neuroscience, like cortisol. We hear a lot around cortisol and all those different things. So can you kind of give us a little bit of basis of like what's going on during this time and why can it maybe kind of trigger this trauma response?
Yeah. So I think I'm going to divide this into two sort of conversations. One, let's talk about the neuroscience in perimenopause itself, and then let's talk about the neuroscience of trauma, because they're two different things. Obviously, trauma in perimenopause, we're going to get the additive effect. But if we look in perimenopause, we know that as, Dr. Quaile really clearly communicated with us, these fluctuations that happen are going to impact us in the brain. And estrogen is a brain hormone too. We talk about it as a sex hormone, but really it's a brain hormone. We have estrogen receptors all over our brain. And I don't want to get too sciencey, but I'm going to because it's helpful to understand the mental health piece, which is when we look at the receptors in the brain, we have estrogen receptors. Why is estrogen important? Well, it affects serotonin and dopamine, norepinephrine. So it has an impact on mood and anxiety, which is going to play a role in trauma as well. So let me just shift to the neuroscience of trauma for a moment, which is that we know trauma actually affects certain parts of the brain. Now, you don't necessarily need to know the parts of the brain, but it's important because they affect certain emotions of ours and how we behave. And so what we know is that when you've had trauma, our ability to process fear changes. That's the amygdala, right? What are our emotions in response to something we're experiencing? We know that actually the volume of something called the hippocampus can go down. Why does that matter? It affects our memories. So it's actually been shown with women who have trauma that if they've had trauma, it affects their hippocampus, which means they're going to have more intrusive thoughts because of that, right? So there's a clear correlation with that. And we also know there's something right in the front of our brain called the prefrontal cortex that helps us think really rationally. Logical reasoning happens in this part of the brain, our executive functioning. And so, it's really important, and we see that decrease because of trauma. Very interestingly, estrogen also is really important for our prefrontal cortex, right? So this is why we have these additive effects. It's like the trauma and perimenopause together is a perfect storm. But we actually, in the functional MRIs, so in MRIs, women who are premenopausal, so if they're not perimenopausal, and they have an adequate amount of estrogen, that their prefrontal cortex is much more activated than when they hit perimenopause. And so, of course, our ability to have logical reasoning and regulating our emotions is better, in women who have not experienced trauma versus those that have, and better before we hit perimenopause. The only other thing I want to talk about is what you talked about, Dr. Quaile, about cortisol, right? We know that our HPA axis, which is actually our stress hormone system. So we experience stress, our body responds to that. We have an increase in cortisol. During perimenopause, where our hormones are all over the place, our cortisol can also fluctuate and we can have difficulty in our stress response system. And that can be difficult if you're experiencing stress. How does your body respond? And that can lead to emotional dysregulation. So basically, you don't feel as in control of your emotions as you would. And that scares women, right? We have had so much control over our emotions. We're feeling good. We can sort of regulate around our kids, our partners, at work. And all of a sudden, changes are happening. And some women may know why, some women may not know why, and then they can't regulate the same way. It makes you feel out of control, embarrassed, and there's a lot of shame. But really, it's a natural, process that's happening, and that's what's impacting our symptoms. So, yeah, hopefully that wasn't too complicated, but I think it's important if you understand some of the bases.
No, I think you explained it so well, like just kind of simple. And I think people kind of want to know, what is going on with me? Why do I feel this way?
Yeah, because it helps them to understand that it's not that it's all in their head or, they're making excuses, but something real is actually happening. So let us now really get to how women present when they have trauma and how that presents in midlife.
Yeah, absolutely. So lots of different ways. So when it presents in midlife, Dr. Raja did such a good job of explaining, and we've talked about kind of the symptoms, but I kind of want to take you through how it may present so that you don't feel like it's all in our head. Maybe it is all in our head because it's such a mood and mind thing, but it's not it's all in your head from a gaslight perspective, if you will. So a lot of times when it presents in midlife, women have this really heightened stress response, especially if there's a past history of trauma. They may notice that there's maybe this more intense anxiety or irritability or mood swings. And it could come from trauma, but it also could just come from they may be more kind of at risk with their symptoms. And it's just because that nervous system is not buffering as well like it would. And it's likely because of just those drops in those hormones. We talked a lot about just the sleep disturbances that are happening. But when we think about trauma histories with patients, they often have this response, oftentimes that's this hypervigilance, or they have these nightmares. And so in general, when that happens, having been exposed to a trauma, then you throw perimenopause all over the place, they're going to have this perimenopausal sleep disruption. So hot flashes, insomnia, all these different things. And then you throw on the trauma response of the hypervigilance and the nightmare. It really impacts sleep so much. And then you have kind of the somatic symptoms that happen. It can manifest kind of physically, this chronic pain, or maybe there's just some GI distress, headaches, and those really kind of often overlap a lot of times with these perimenopausal complaints. And it really kind of makes it harder to parse out okay, is this trauma response? Is it somatic response? Is it GI? Is it perimenopause? So it makes it a really complicated time. And then I think it's also important, one of my favorite things to talk about is just ACE scores, adverse childhood experiences. I don't think that we spend enough time in clinics asking these ACE scores. It actually was it's a series of 10 questions. It was actually put out by Kaiser several years ago, and it looked at different situations that children are exposed to before they hit adulthood at 18. And those experiences, depending where your ACE score falls, they say that anything of a score greater than 4 puts you at higher risk for trauma. And we know that with those past experiences, that can lead to a lot of different changes. So these transitions that are going on, maybe can really kind of trigger that response. And then kind of with these hormonal shifts, that kind of really interplays with trauma. We've said there's estrogen decline, and we know that estrogen, it really supports a lot of the different neurotransmitters in our brain, serotonin, dopamine, norepinephrine. And kind of as estrogen falls, it impacts those neurotransmitters. So women may experience, as Dr. Raja had said, these heightening experiences, just depression, anxiety, maybe these intrusive thoughts. And then with that cortisol, what that's kind of doing is maybe it's amplifying more of that fatigue and the brain fog, or this wired yet really tired state. that's going on. And we know that progesterone really kind of has this calming effect on our body. It works on GABA receptors in our brain. And so as that kind of drops, trauma survivors may feel like more of this anxiety and the dysregulation that can happen. And then for testosterone, these lower levels that happen because we know it's starting to decline, that really kind of impacts that. Maybe their resilience or their motivation or their feelings of confidence. And they kind of feel like, I've become a shell of myself. It's that NFLM, not feeling like myself. It's the typical response that we often hear from our perimenopausal patients, that they just don't feel like themselves. And so they really kind of feel like they're on this emotional ride. I think it's also really important to kind of talk about sexual health in here too, just because you start to notice some changes that are going on in the body hormonally, genitourinary syndrome of menopause. Everything kind of becomes more drier, more irritated, and a trauma history already that's there. And then you have these changes that are going on vulvar and vaginally can also kind of cause these more of a sexual health response, libido and things, because maybe there's some avoidance or pain or fear of intimacy. Again, with that. So I think all of those symptoms kind of happen a lot during this time frame, but I feel like they're very heightened for people that have experienced trauma.
It's so clear that there's so many different ways that trauma can manifest in someone, right? And it's not like one size fits all, like a woman's going to come in and we're like, oh, she's had trauma and this is what she's had, because really the manifestation of trauma is so different from woman to woman.
Absolutely. So when a woman comes in and sees you, I think, again, it's such this biopsychosocial approach. And I think it's why I just love your lens of psychiatry, because I think that women kind of want to know, like, am I going through everything? There's a lot of things hormones can do. And I'm a huge advocate of kind of a hormone first approach, but they're not going to fix everything. And so some patients need other modalities of care to kind of work through trauma and maybe other kind of medications. So what do you kind of recommend for patients? And in particular, like, what are some options that you like for them in this midlife timeframe?
Yeah, great question. So as you very clearly noted, hormones are definitely an option, right? Depending on the other symptoms. And if it's very clearly activated, the trauma is activated during perimenopause, we can absolutely use hormones. Not that it's an FDA approved reason to use it, but if we're treating other symptoms, that is an option. But we have other medications we can use. So we know there are antidepressants and anti-anxiety medications that can be really helpful for PTSD symptoms or trauma symptoms, depending on, again, how the woman is presenting. I think what often gets overlooked is therapy. Trauma needs to be processed. I think so often we just want to sweep it under the rug because there's so much shame about trauma. Women feel like, I must have done something wrong, or maybe they're gaslit into thinking they did something wrong. And so I encourage all women, but definitely women who have had trauma, to seek out therapy. And there are really validated therapies for trauma care. And I would say there's cognitive behavioral therapy, or CBT. Side note, there's a CBT for insomnia, which can be really useful. So if you're having sleep disturbance, that can be really helpful. There's also EMDR, which is eye movement desensitization. And that's a specific type of therapy that's been, that's evidence-based for trauma. We also have other modalities like somatic experiencing. So what happens there is you're really processing and expressing your needs, but it's more in your body, less in your mind. And we have something called a stellate ganglion block. So these are, a cluster of nerves in the back of your neck where you can get an injection there that has been shown to be really helpful for PTSD or trauma symptoms. So, you can see there's really a wide spectrum of treatments. And of course, we can't forget the basics, right? We have mindfulness, we have yoga, we have exercise, we have, walking, just like really just walking. And I say just walking because some people think like, what am I going to get from that? Well, it does help with, being out in nature helps, and walking helps. It releases certain hormones that can help with the trauma symptoms. So I think, knowing that there's so many different treatments is important. But if I can really leave you with a main idea from this, it's making sure you're with a provider who understands trauma, right? Trauma-informed care, and Dr. Quaile is like an expert in this, and that's why she talked about ACE scores, because most providers don't talk about it, but they don't really want to get into the trauma because it's hard to treat trauma if you don't have the time or you don't want to make the time. So, with trauma, if you have someone who's doing trauma-informed care, they're there to listen. There's a safety that's built. There's an understanding of what your trauma is and really trying to avoid re-traumatizing the patient. There's a collaborative effort, right? This isn't a paternalistic sort of relationship where I tell you what to do and you just do it. We're going to have a conversation. There are choices. And that's why, we talked about what are your choices. We really want to empower the patient to make decisions with us. And so I encourage you, if you're looking for treatment, to really consider this as a piece of this. And I tell women, trust your gut. If something doesn't feel right, you're not being heard, you probably aren't. And it's important to get a second opinion. But there are treatments available for trauma and you don't have to just hold it in.
The one thing too that I want to say on trauma-informed care, because I can't not speak to it because it's just my passion work, as you know.
Yes.
And one of the things that I kind of had talked about in some of the platforms is like, I think if we come to every experience, whether it's healthcare providers or whether people that you interact with as lay people and expect that they have experienced trauma. Dr. Raja has experienced trauma. I have experienced trauma. Maybe it's not big T trauma. It's these little T traumas. I think if we could change the narrative, and one of the words I like better is I think trauma holds so much connotation for a lot of people. And so we think about it as this big catastrophe and that everyone can't experience it. But I think if we surrounded it, one of the things I talked about in my last lecture with it is, who knows what the golden rule is? Like, what's the golden rule? Just out there.
So do unto others as you want done unto you.
Exactly. Simple, basic. We learned it in kindergarten. We taught it to if we have children, you taught it to your children. And I think if we came with the approach of the golden rule and people-centered kindness and care, and we rephrased it out of the word of trauma-informed care. We really are actually doing trauma-informed care for our patients, but as people interact with one another, instead of thinking of trauma as this big, huge word and thinking about it as just being people-centered, following the golden rule, I think that really puts it in a perspective that takes it back to simple English language, simple to understand.
I just love that. I love that because there is such a stigma with just the word trauma, right?
Yep.
You say the word trauma and everyone sort of, you can see the reaction in the room. And I think patients feel that. And I know, Dr. Quaile, you and I were talking a little bit about this. And, when patients go see a provider and maybe there's gaslighting there because of their history of trauma. And that can be, quite challenging to deal with. And just using that word trauma can really trigger that.
It can. And I think you said it's really hard to come to a lens and practice trauma-informed care in every interaction. And I agree. I think there's a lot of training that needs to come with it. But I think if we just go back to our basic kindergarten of the golden rule, how do you want to be treated should be the exact way we treat others, whether it's in a doctor's office, if it's at the bank, if it's at the grocery store, if it's friend to friend. And I think if we can just come back to that basic, we really are being trauma informed in all of our interactions.
I love it. Golden rule informed.
Golden rule informed. I've been trying to kind of up with some, and in my last lecture, I was like, this is what it is. Okay. Yeah. So Dr. Raja and I want to spend some time going through some like vignettes for you all, where we kind of give you these examples of like what's going on, how was the patient kind of made to feel, and kind of talk to you through them because maybe you've experienced this. And so I'm going to let Dr. Raja kind of take it off, and we have about 4 case examples, and we'll do what we can get through before we wrap up in the next like 25 minutes or so.
Perfect. So the first case, this is Maria's story. At 47, Maria had severe night sweats and insomnia. Her provider told her that's just what happens when you get older. You'll get used to it. She left feeling dismissed. Yeah, that happens all the time, doesn't it?
Absolutely, it does. Absolutely. So when a patient feels like she leaves feeling dismissed, like I'm sure you guys have kind of felt that way. So I guess let's kind of talk about it from like a patient perspective. Like what are some ways that they can maybe talk to their healthcare provider or how they can kind of advocate maybe for themselves?
Yeah, I think talking about what the real impact of that is, on their lives and how things have changed for them. I think it's important to show your baseline and how your baseline has changed. I say this to my patients all the time. Like, my goal is to get you to your baseline. And so what does that entail for you? And for everyone, that's different, right? And so I think really for patients to be able to say, like, this is my baseline, this feels off. So yeah, that's where I would start, because I have done this many times. I will write sleep on a prescription pad. I know you can't pick it up at the pharmacy, but to me, it's just as important as any medication, because it truly impacts how women feel. And so, yeah, I think it's something that we have to advocate for ourselves. And when we know our sleep is off, and it's not just because, of a one night off, that you didn't sleep well, it's important that we really address it.
Yep. And I think you talked a little bit about CBTI. Can you explain that just a little bit more for people so that they even know like what to look for? Because it's actually something I'm kind of even newer to as a healthcare provider.
Yeah, so CBT is cognitive behavioral therapy, and they formulated a very focused CBT, cognitive behavioral therapy, for insomnia. So it's for sleep. And so what is cognitive behavioral therapy? We're really looking at your thoughts that affect your behavior, that affects how you feel. And so what CBT does is it looks at it for sleep specifically. And if I'm not mistaken, it was developed by the VA, and they may actually have a free program, whether it's an app or online, I can't remember. But this idea that, most people for their sleep just want a pill, right? Give me something. Just give me something and knock me out. But what's the root cause of your sleep issues? For some people, it's sleep apnea. For other people, it's their anxiety. For other people, they have a circadian rhythm issue, and that's where melatonin can be helpful. So I am a big believer in treating the actual cause rather than throwing medication at you. And so CBTI is helpful I think it's a great first step. It's non-invasive. It's something that's pretty easy, because there's a free program, the access is there. And I think it sets the foundation anyways. It talks about sleep hygiene, and then also, how to change your thoughts around sleep.
Absolutely. And so I think it's really important. Hopefully what you're kind of getting out of this little vignette, is that if you feel like you've gone to your healthcare provider, maybe you've seen this person for years and you've felt dismissed, but you don't feel strong enough like going somewhere else. I think it's really important that you're with a provider that like listens to you and gives you an explanation of your choices, and they work with you to kind of find relief. And if you're not finding that, it is okay to look for a new clinician that may work better with you. I think that's kind of important.
Absolutely.
Okay, so let's go on to kind of case number 2. We have this kind of as this little misdiagnosed patient. We have Aisha. She's 44. She developed some heart palpitations and some hot flashes and anxiety. And she was told, it's all in your head. Why don't you just try yoga? And she actually left feeling pretty blamed. That happens a lot. I see a lot of patients in my personal practice that come in and say, "Hey, I saw someone." What about you, Dr. Raja? Have you kind of heard this typical scenario, unfortunately?
Yeah, all the time. And I think when women feel blamed or they feel guilty or whatever that word you want to fill in the blank, sometimes they stop seeking care, right? They just like go home and say like, it's a me thing. I'll figure it out. And they suffer for a little longer, and maybe they'll reach out for help again. But I think for so long they don't. And yeah, it's unfortunate.
I think you said something super key. They suffer. They continue to suffer, and they think that it's okay. Like, you shouldn't have to suffer. And that really kind of hones in with me. Like, I agree with you. I think there are so many women out there that can't navigate good care, and they just feel like, okay, I just have to suffer. And women shouldn't have to do that.
Yeah. And I think the hard part, as a psychiatrist, as I'm coming at this case, the hard part is, you have palpitations and you have anxiety, and you go to, if you don't know, you might just go to your primary care, you might go to an OBGYN, you might go to a psychiatrist. My guess is you're probably going to go to your primary or a psychiatrist, right? And not everyone knows that this could be related to your hormones. And that's not to pat myself on the back. That's to say, as women, I really want us to be able to advocate for ourselves when we feel like something's connected to something else, as opposed to just taking whatever is thrown at us, right? So, if you're in midlife and possibly in perimenopause, early, mid, late perimenopause, and here we are, you're having a panic attack for the first time, or the first time in 25 years, that's not a coincidence, right? There's something hormonally going on, and we need to have either a women's psychiatrist or the collaboration with, a menopause specialist and a psychiatrist, but really coming together to say, like, what's the root cause here? And it seems much more hormonal than it does, a new onset of panic disorder at age 48.
And I think that's so wonderful in a lot of ways that psychiatrists are starting to take this on and that they've shown a general interest. I think part of the problem is that in our, over the years, as we both know, the Women's Health Initiative did so many bad things for really kind of shutting down hormone care for women. All these women were on it. It was like the best thing in the world. And then all of a sudden the data came out, and it was actually pretty cruddy data now that we've gone back, extrapolated, and spent the last 20 plus years kind of debunking everything. But the problem still is that there was such a significant amount of women on hormone therapy, and now we are only at 5 to 10% of the population on it. And one of the things that, and you may have been on this post when we were posting about it in Instagram the other day, this really kind of like hit me like a gut punch that a patient said. I'm always out there on my Instagram saying, advocate for yourself, do things for yourself, go get a new clinician if you don't feel seen and heard. It's time to find a new one. And one of the things that just really left me like speechless the other day is that someone who follows me said, well, why are more clinicians actually just learning how to care for this and how to see the symptoms and going back and wanting to learn so that we don't have to go find a new provider? And that was a very like aha moment for me, because a lot of us, I'm not trying to say that there's a reason, like the reason why there was such a huge gap is it took a long time to debunk all the information, but also all of the, and I hate to say it, the oldies that were writing for hormone therapy didn't teach the younger people. So we had this, again, huge gap where a lot of us never learned it in school. And I'm not saying that that is proper and right, but I mean, I got probably an hour and a half of education in my training. And I don't know, did you get any in psychiatry?
No. No, I don't even think we use the word. And you know what? The other day I went to my psychiatry residency program and I taught about it, because it's like, we're not doing this anymore. So I agree, why aren't more, providers learning? I agree. We need to help more providers learn. But right now we just don't have that happening everywhere, right? I mean, I think it depends where you live, what resources are there. And I blame it on the system, to be very honest with you. Yeah. Yes, I get, people can learn, but it requires time and effort. And, we have to create this as a public health issue, really. Absolutely. It's not something that we can just say like, hey, learn if you want to. This is like, if you're seeing a woman at any point in her life, like, you should know that hormones can impact her head to toe.
In every chapter of her life, not just in menopause, but in puberty, yes, and in postpartum and in like all the different phases. Yes. And the reality is all healthcare providers, for the most part, that take care of people, they probably will take care of, unless they are solely focused in men's health, they will probably take care of 50% of women. And so we've really done a disservice, unfortunately, to women. We need more research. We need lots of things, but we're trying, or there's just not enough of us out there. But that kind of was really eye-opening, and why you really need to come to these type of supportive webinars so that you can, for now, until we get more providers trained, kind of fend for yourself, so that you really are having your concerns like listened to, and that they're checking on everything. And I think it's also important too, to also say, like, Dr. Raja comes at it from such a beautiful lens of actually being a psychiatrist, but also learning hormone care. So I will never say hormones are going to fix everything, or they're the amazing thing in the world. There are people that I always say, I want an 80% improvement in your symptoms, but you know what? They still may need an SSRI or an anti-anxiety or to see a psychiatrist. And I think that it's also important to kind of get rid of the taboo around those medicines.
I couldn't agree more. And I think it's not always an or, sometimes it's an and issue. And that's where the nuance comes in, right? And it's okay to say, I don't know, like I prescribe hormones, but there are complex cases that I would refer to you, right? Because this is not what I do all the time, but at least acknowledge that it exists. I think that's really important. 100%. And I think for me, it's like the suffering, but also let's look at the real, let me get a little bit deeper, right? Trauma in women can also lead to chronic illnesses. Mm-hmm. That can lead to increased mortality. We're talking more women dying because their trauma is untreated. And it's not to dramatize it, but let's call it what it is. 100%. This isn't just us saying it's trauma. Let's put fluffing it up. It's no, these are real issues. And it's not as obvious as a heart attack, right? We don't have labs for it, but we know chronic stress with increasing cortisol impacts all of our organs.
Yep. And I think we got to go back to ACE scores. I mean, we don't talk about it enough. So if you have an ACE of 4 or greater, the data is there. There's actually evidence on it that is more putting you at risk for chronic disease. And so then if you have chronic disease that's there, that of course is going to impact your hormones. So I think what I want us to take away from this is that every single midwife woman, maybe she will not use hormones, but she darn well does a discussion about what your hormones are doing, how they're impacting your care. And you get to make a decision with your clinician. Should I do hormones, or are they not the right route for me? Or do I need something else? And every woman deserves that discussion.
I love it. Yep. Well, let me go to the next case. That works. Let's do Sarah's story. At 50, Sarah had painful sex and vaginal dryness. Her provider shrugged. That's just part of aging. Use some lubricant. Sarah felt embarrassed and avoided care. Dr. Quaile, you must see this all the time.
All day, every day. And I think the hard part is when a patient comes, so I wear a lot of hats, but I think one of the ones that is the most passionate to me outside of trauma, and it probably is because all my worlds align, is sexual medicine. It is really hard for a woman to come in and talk about her sexual health concerns, to talk about her libido, to talk about pain with sex, because it's such an intimate discussion and it's very taboo, and our society has really done a bad job of giving sex education to us in our younger years, and to all the misinformation and misconceptions that come with it. So when a woman feels brave enough to say that something is hurting and that there's dryness, and to kind of get shrugged off, it's just so dismissive. And it's one of the things, unfortunately, I hear way too much, and I'm hoping over the years it gets better, but I probably could tell you I hear it multiple times a week.
Yeah, I thought I'd never do this, but the other day I prescribed vaginal estrogen cream because I just got to the point where it was look, I can refer you, but at some point, you have this vaginal dryness, it is hurting you. We talk about really intimate things in psychiatry, so it comes up. And I ask about pain with sex all the time. And, we got to get comfortable talking about it. This is just like anything else. It's part of their, well-being. And so I love that you brought this case in. What are the options that women have, Dr. Quaile, in terms of these symptoms? And I know, we were talking about trauma in general, but I think, women who have these symptoms can often feel re-traumatized, and it would be great if they have improvement in these symptoms.
Yeah. So especially when something comes, let's say from big T trauma, let's just go to sexual assault, and that's there. We know that is just a horrific act to have been through, and your body responds in certain ways, and it's something that you're going to hold on to forever. And then we know that that's going to put you more at risk for chronic disease, midlife changes, symptoms, and other things. So when things start changing in that urogenital tract and in the vagina and in the vulva and those changes, it can be really scary to someone that has gone through a horrific trauma, such as a sexual assault. So maybe they have finally kind of come to grips, or maybe they've gone to counseling. Maybe they haven't, but let's just take the patient maybe that has gone to counseling, has worked through it, and now maybe they're able to be intimate, either through self-stimulation on their own, or maybe they're able to be intimate with a partner. And then they start to see all these changes that are going on in their body. It can be very triggering and very scary, like, oh my God, am I broken? Or I don't know if I can even mention this to my provider. So one of the big things that I encourage is that maybe even putting it like when you're filling out your patient forms, if you're not maybe comfortable like having that conversation with your provider and it's someone new that you're going to see, maybe you can put it in other, like I'm having some dryness or I'm having irritation or sex hurts, and kind of see if that will open it up. When I teach providers, I tell them things like put it on your intake form. It opens up the discussion to have that. Because we know that as estrogen depletes, it really is impacting those vaginal and vulvar tissues. And it really does lead to making sex very uncomfortable and painful, and it shouldn't be. And there are things you can do. So it makes me super excited to hear that a psychiatrist is prescribing vaginal estrogen, because that is going to be kind of that first line, is just putting some estrogen back in that vaginal tract. But then also I have to put a little plug in for the International Society for the Study of Women's Sexual Health. I can't not talk about this topic without kind of talking about my medical home that taught me everything about sexual health, is that your tissues on the outside are also innervated by androgens. So she may need a little bit of testosterone to her vulvar tissue, and she may be really hormonally deprived during this time frame, that you may need more than just vaginal estrogen. And you need a really good workup if sex hurts, because it shouldn't. If the estrogen and the hormones aren't working, then it's time to see someone who can help evaluate like where your pain is. And is it a muscular pain? Do you need a pelvic floor physical therapist? Kind of what's going on there.
I love that you mentioned the pelvic floor physical therapy, another, I think, underutilized, treatment modality we have and can be really helpful for women. So yeah, absolutely.
Yeah. Absolutely. Okay. So in our last little bit of 10 minutes, I want to go over our last case, if that would be okay. So this is number 4. We have Kim. She's 46 years old, and she's felt kind of more irritable, forgetful, and depressed. And her provider says, everyone feels that way. You're just overwhelmed. And she kind of has this feeling like, well, maybe I'm just weak. Maybe I need to just suck it up. So do you see that, Dr. Raja, in your clinic? And kind of what does that look like for this type of patient?
Yeah, I mean, especially I see this all the time. I think the irritability is really concerning for women when that irritability starts, affecting their relationships with their partners or their children. They get scared that their personality has changed and that they're bad moms. And so it's really talking about, again, what we've talked about today so much about the hormonal changes and really educating them that mood changes happen in perimenopause, right? The forgetfulness happens with the brain fog. A lot of women come in really worried that they're going to get early onset dementia, especially if they've seen someone else go through it. And it's not to say that we want to just dismiss that, but we can educate about the risk of that as well. I would say, there are multiple avenues of treatment here. Of course, we have medications, we have support groups, we have therapy, but really just making sure that women are educated to know that this does happen and it's real.
Absolutely. Absolutely. I mean, I think that's super, super important, just to validate and make them feel like they're being heard. Debbie had asked, how do I not drive us from getting a divorce? And I think that's just such a fair question. Do we kind of want to dive into that a little bit? Because that may have been something we didn't answer.
Yeah, I mean, I think it's such an important, concept. I mean, this is, you may have heard in the media, this whole concept of divorces, because we do know that there are a lot of relationship changes that occur during perimenopause, and it happens for a reason. There are changes that happen. And I would say, first and foremost, make sure everyone's educated on what's going on, right? Just like I want women to understand their bodies, I want men to understand women's bodies and hormones, just like I want women to understand men's bodies and hormones, right? So I think it's fair to say that it's important that we educate our partners. And then what are we doing about it, right? I think, yes, we know there are treatments available. It's not one size fits all. We know that, we have to get different treatments, but I think we want to work on the relationship. But I think if you are struggling and you're trying to work on the relationship, it's just not going to go well until you actually feel better yourself.
Yep. 100%. I think the other thing that's important too is there are people out there that are trying to educate more of partners, especially our male partners, kind of what to expect during this menopause, perimenopause transition. And I think just having the conversations with your partner, especially if you're in these heteronormative relationships, kind of what this looks like and kind of help them navigate it, or even just sending them like, hey, here's an article I read so you can kind of understand that I'm not crazy. It's not all in my head, and just really have good support from your partner. I think that's key. And I think another thing that's also important too is that they're trying to get more information about menopause in the workplace. And I think it's so key on that, because most of us that have kind of hit this time frame in our life, a lot of us that may have children are getting close to empty nesting, and we may be in a different place. We can work more. We're kind of, a lot of us at the pinnacles of our career. And then all of a sudden, all these symptoms come crashing. Your hormones are all over the place, and that really impacts work. And I think when work is not super knowledgeable in the workplace, like this is a normal process that women go through, and have supportive resources that are out there, I think that impacts a lot of things as well too.
Absolutely. And the Menopause Society has some great resources, whether you're an employee, an employer, really starting to talk about menopause in the workplace, because there's great evidence to know that a lot of women leave the workplace during this time in their lives because it's not manageable for them. And that comes from many different angles, right? Whether they're not getting the treatment they deserve versus, their workplace not really understanding what's going on, resources not being available for them in order to accommodate them. So I think there is a lot of work to be done there. But I have hope that as this conversation continues, so will that one.
Yes, hopefully so.
Well, this is wonderful.
Yes.
Thank you all for being here.
Yes, thank you. Thank you so much for having us. And if you want any questions or have any questions, I can drop my email. I'm comfortable with that in the chat.
There you go. We have both of our emails in the chat, and have a wonderful rest of your day.
All right, everyone. Take care.
Bye.
Bye.